Good afternoon, moderator, panelists, and all participants. My name is Nachapan Pengrung from Ramathibodi Hospital. Thank you, the trauma section, for this opportunity to present the case discussion. Okay, let's start with the case. The 71-year-old woman came to my hospital with pain and groin and back for 3 days. The pain occurred after she fell on the floor while she was sitting on the chair. She couldn't walk due to pain. She had the underlying disease of hypertension, Alzheimer's disease, and spinal stenosis. And this is her current medication, was shown. The examination at first showed no external wound and tenderness at the pelvic symphysis and left groin area. She can do the active hip range of motion with pain, and distal neurovascular status was intact. This is the pelvis radiograph, and it shows the fracture line at the superior pelvic lemma with a little bit displacement. The location of fractures was very close to pelvic symphysis, and other parts seem to be normal.
Okay. So we should stop now. Some discussion from you right now, or we have to wait for a while?
I think in this case we need a further investigation, but from the history, it's very important to address that the patient had Alzheimer's disease. So is the main issue that we need to consider that they will walk for sure. They will forget what they had, and they had some difficulty to mobilize. So this is the main issue that we need to bring in on.
So any comment from you, please?
After CT scan.
Okay. Okay. We wait for the CT. Please get some more information, please.
Okay. Thank you. When you see the patient or get the consult with the patient like this, don't forget to evaluate carefully from the history, examination, and investigation. First, the history, you should concern about the pre-injury level and ambulatory status, and also cognitive function. And pay attention to the examination as the posterior ring structure, and also complete the radiograph and CT scan. So in this case, this patient can walk without gait aid before the injury. And for the cognitive function, she was in the Alzheimer's status, so she could not well follow to command. And for the examination, she had the general tender at the posterior structure, so the posterior pelvic ring injury is very suspicious. And the X-ray were as follows. I'm sorry that I don't have the complete film, so we just had only the inlet view and lateral hospital view. And then I will show the CT scan later. From the inlet view, which you can see that there are also the displacement in inlet view, and for the lateral view, there are the kyphosis deformity at her sacrum. And this is the CT scan from the coronal view. This is the posterior ring. And for our sagittal view, and for the last axial view. And I will proceed. So the diagnosis and classification at this time, I diagnosed she was the fragility fracture of her pelvis I classified by Lommen classification type 3, and she also had sacrum fracture at Dennis zone 1 and horizontal fracture as sacral 4 fractures. And from the superior pubic lemma, I classified the fracture to Nakatani type 1. And may I ask the panelists, what is your plan of management in this patient?
So please, from you first, Mr. Jim.
Yes, this is a key question. Surgical or conservative treatment. The previous lecture, he introduced the classification of Lomans. However, in clinical situation, the golden standard of this kind of decision is examination of under anesthesia, the stress test. Have you done to the EUA for this kind of pelvic injury? No? No one? Under anesthesia, you put the pelvis come together, and at least 1.5 centimeter more than the displacement means instability, or the motion of the posterior pelvic ring means the instability of a pelvic ring. That means indication of surgical treatment. If not, stable pelvic ring injury, there is no need to surgical fixation. That is a very simple test. It is a golden standard. However, this kind of examination require the surgical theater to make anesthesia. So this is another alternative, a very simple way to determine the surgical indication. I use it, and several papers already published by the Denver Medical Health, my friends, Sarah Murphy. That is when the patient come to the emergency department or your outpatient clinic, patient check the pelvis AP X-ray in lateral decubitous position. When this patient has the right side of the fracture, and the left side is down and right side up, lateral decubitous position, just check the pelvis AP X-ray, like this one. And then the lateral stress test shows the more than 1 centimeter of displacement. That means the pelvic instability. So it's a very easy and reliable test to determine we can fix or not. So that is my comment.
Thank you very much. Any idea from you?
Okay. So in this case, we obviously found that at least there is 2 disruption of this pelvic ring, the posterior and the anterior. So the fracture is not stable, and we need to fix it. And of course, the goal of the fixation in this fracture is complete the whole ring fixation, because we can see the case from the previous lecture from Dr. Nachapan that if we fix only one place, it may displaced later. So when we need to fix these fractures, of course, the patient is elder, we have to think of the minimal invasive technique first. In the posterior, I think that we can do the SI screw insertion. It's not a big problem. And for the anterior, because the fracture is located very close to the rami, very close to the pubic symphysis. So I think that the percutaneous retrograde screw fixation is not able to achieve a good reduction and not able to maintain the fractures. So personally, if the fracture is too close to symphysis like this, I prefer to use the interpelvic stopper approach to fix the fractures by using the plate to complete the whole construct. For the fractures at the sacrum, because it's located at S4 level, so I think it's not affect on the stability, so I may leave it conservatively. Okay.
Okay, so we have limited of time, so please go ahead for the case.
Okay. So I decide to perform, after we discuss to patient and caregiver, we decide to do the operation because of this unstable type. Okay. I will proceed to intraoperative view. Okay, in the operative theater, we do the examination under this year as well, and found that there are some widening of the left SI joint, so we decided to perform the bilateral iliopsoas screw. For the S1, we used 7.3 fully test cannula screw with washer, both sides, and we use the 5 millimeter cannulated screw. The small diameter one is from the proximal femoral locking plate for both S2 because of the small corridor for application. And then we move to anterior view modified stopper approach, reduce and fix it with the 18-hole reconstruction plate. We span plate to both of supraacetabular area and fix the screw to purchase the hard bone. And this is the post-operative radiograph in AP view.
Okay. May I ask some question about the approach in your Professor G? Do you prefer to do the fixation on the posterior first or the anterior first?
Usually posterior first. This fracture has the anterior fracture is very close to medial, the specific pubis, so it is not easy to fix the single screw. So you choose the plate is very reasonable, but you use the stopper approach. The plate should be placed here, intrapectineal. This thick area is very reliable to fix the screws. This area is not reliable, so the screw should be placed here. A very thick area, even in severe osteoporosis patients, we can fix the screw firmly. So this approach is good, but the place should be infrapectineal. So you can purchase 2 thick cortical bone.
Thank you. How about you, Dr. Nachapan, please?
Yes, I do agree that mostly I fixed the posterior first. At this case it was 2017, right? At that time, we don't have the long screw to purchase both SI joint, but now we have it. So I think that sometimes we can put the screw at 2 levels and purchasing 6 cortex from the iliac wing to the other side at the same time. And for the bone corridor, I think that in some cases, which are very fragile patient, I think many surgeons may not comfortable to do the plate fixation in these groups of patients. I think that the other option is the external fixation, but we can combine it with the SI screw. It can provide the anterior stability, and the patient still able to ambulate, and we can remove it after 2 or 3 months. Is the option for the very fragile patient.
Okay. How about after the fixation, what next?
Yes. The patient was ambulated with wheelchair and walker and the medical supplement and started anti-osteoporotic duct. And this is her BMD. 6 weeks post-operation, she got a painless motion and can perpetuate wearing with walker. And then 3 months, she can full weight bearing with walker. And there are some healing of the posterior and anterior wing. Thank you.
Okay, so please give a big hand from him. Appreciate.